DESTINY-Breast05 was really a follow-up study to an earlier landmark study, the Catherine trial, that had shown us that patients with HER2 positive early breast cancer who had received our best neoadjuvant chemotherapy but were found to have residual invasive cancer did a lot better with T-DM1 than they did with Trastuzumab. And that was important because two reasons. One, it really established neoadjuvant therapy as a standard of care because that treatment identified a population of patients who would derive substantial benefit from T-DM1 that you would otherwise never see. So that's why it was such a crucial study. For the first time, we had something to do for the patients who did not have a complete disappearance of all the cancer in their breast. When we looked at the outcome data at the early initial evaluation, the 3-year invasive disease-free survival, we had really very robust outcomes for half of the population. But the group of patients who had a advanced cancer presentation, T4 primary tumor, N2, N3 nodes, or patients who still had nodes who had positive nodes in their axillary specimen, had already at 3 years were having a risk of relapse that suggested, we're going to need to do something beyond T-DM1. They had a 50% improvement, but because they started out at such high risk, a long way to go. So around that time, we were seeing the first reports about this new drug, T-DXd, that just showed remarkable activity in heavily pretreated patients, an amazing waterfall plot. And basically with that data, we launched the DESTINY-Breast05 in those high-risk patients to see if we could do better with T-DXd than we did with T-DM1. Not that T-DM1 didn't help, it just didn't help enough. So the trial was straightforward. We basically took the Catherine eligibility criteria and added that we wanted the subset at high risk, patients who had had the locally advanced inoperable disease when they presented or had positive nodes, were then randomized to either receive standard 14 cycles of T-DM1 or 14 cycles of T-DXd. When we looked at developing the sample size for the study, we thought that given the potential toxicities of T-DXd, particularly the interstitial pneumonitis, we'd want to see a substantial risk reduction from it. So we kind of powered it to see about it. It was a 0.675 to be precise, hazard ratio that took 1,600 patients. It gave us 80% power to do that. As we always do in these studies, we built in an early interim evaluation in case the results were better than what we had targeted for, and that was the case. When we planned our interim analysis at about 75% of the events it would take to see something for a hazard of 0.675. Our IDMC said, guys, you're there now, and that's when we saw the data. Our hazard was much better. It was 0.47, so we had a 53% improvement with T-DXd relative to T-DM1, which was obviously very gratifying. The other aspect that we saw as we followed up Catherine was that the drug T-DM1 unfortunately did not help us with the problem of brain metastases, which is a big issue with HER2 positive early breast cancer, particularly higher stage disease. And as T-DXd was developed, it was evident that it has a lot of activity against brain metastases. So we were also pleased to see that early on in the study, numerically, the T-DXd arm does have fewer patients with CNS metastases in the T-DM1 arm. So it's still early. It was 25 patients in the T-DM1 arm, 18 in the T-DXd arm. So numerically better, but we're going to need follow-up for that one to firm up. But that was another encouraging sign we had in the trial. Yeah, in terms of toxicity, in general, the T-DXd produced the side effects that we expected to see from the development of the drug in metastatic. We see more GI toxicities. You have to use antiemetic therapy. The real critical thing that we were, of course, watching was for the problem of interstitial lung disease. And one of the aspects of moving the drug from the metastatic into the early setting is we added low-dose non-contrast CT scans at fixed intervals. We did it at baseline, 6 weeks after starting treatment, and then every 12 weeks while on treatment, with a final one 40 days after the last dose of drug, solely for the purpose of identifying hopeful early ILD, where it was just showing up on imaging, minimally symptomatic, where the symptoms may be mild enough that you might miss it. So that was an important part of the study. And what we saw was that overall with that, we had 9.6% of the patients. So it's essentially 1 in 10 patients develop interstitial lung disease or pneumonitis. And we did add a step on the trial to really try and get very objective expert calls on those things. What we did was when adverse events were reported, we had like 56 terms related to lung problems that would trigger, let's pull those scans in and review them. If we had a diagnosis of pneumonitis based on a scan local read, we pull them in and read them. So we had a adjudication panel of experts who looked at the scans not knowing if they were getting TDM1 or T-DXd. The site doctors knew that, so there's always that question of bias a little bit. This way we got independent, unbiased experts, and that's where these adjudication numbers came from. Most of them were grade 1 or grade 2. 8.5% were grade 1 or grade 2. We just had 7 patients with grade 3. We did have 2 patients who died from interstitial pneumonitis, so it would be grade 5. And when we talk about the gradings, we're always describing the most severe toxicity the patient experienced. So we had no grade 4s. Presumably the patients who died at grade 5 passed through that, but that's how those numbers are kept. It's always the highest grade toxicity. The thing that we are still looking at very hard and try to have more details by San Antonio is the critical question of recovery. We do know investigators were asked, is this adverse event recovered? Is it recovering, or is it not recovered in their judgment? And the majority had said patients had recovered, but there's questions in, well, what does that mean? Does that mean the CT normalizes? Does that mean symptoms disappear? So it's that kind of granularity, because I think a critical aspect in early will be the reversibility, and ideally the total reversibility of this side effect, because potentially if you leave somebody with chronic lung problems, it's been a high price to pay. So this is still a part of it, but we are dealing with numbers in this high risk group with the large benefit, where it's clearly worthwhile. But it's when you start thinking about the earlier setting more broadly, you really do want to know, and it helps to talk to patients about risk benefits and things of that type. Well, next steps for the study is, of course, it's early follow-up. We will update the analysis sometime next year when we get to the originally planned 207 events. That's where the endpoints will be updated. In the meantime, we're going to be looking at the quality of life instruments that were collected. We'll start the translational work on it. I know we're very interested in looking at ctDNA clearance in the trial. We collected specimens to allow for that, and getting a lot of granularity on the pulmonary toxicities, the recoverability. We're also going to do some more. We had some pre-specified groups where we did subset analyses. There's some other subsets that are of interest that we're going to be reporting on. HER2 IHC status. In Catherine, the 2+ patients who were FISH positive didn't seem to get the same magnitude of the benefit as the 3+. We're interested in seeing how T-DXd does, because we know it's active in HER2 low. So these are so with that lower HER2 expression. So these are things that we're going to be working on, and we are going to have a oral abstract at San Antonio with more information. Well, T-DXd has really been just a transformative, remarkably active antibody drug conjugate in the HER2 positive metastatic breast cancer space. I think DB05 provides the important long-term invasive disease-free survival endpoint that really tells us, yes, there will be value for patients, benefit for patients with early cancer. The challenge is going to be identifying, getting back to the pulmonary toxicity. What is it? Do we just stay in the high risk? What about intermediate risk? These are things that are sort of the next step. But this is a critical point where we do move into, now we can say, yes, there is evidence in these long-term endpoints. We heard from the Destiny Breast 11 neoadjuvant study that the drug for 4 cycles can increase pathologic complete response rate. So, this is kind of beginning this process of really figuring out where we really need the drug, where patients will benefit uniquely from the drug. When can we do fine without it? That's the nice thing about the HER2 positive space, is we have so many effective drugs. It really gives us an opportunity to think more about an individualized approach, because we had been working a lot on the idea. The other thing Catherine did is it allowed us to think about, well, instead of just having to have everything up front to try to get that pathologic complete response as high as possible, maybe if we can back off the therapy and get most people there, we can, cure some patients with less. Those who need more, we identify them. So this is all part of the treatment paradigm that's evolving, and this is another, important step in that overall process.